Three, two, one. Hey, what's going on, guys? Jerem Dastrup here with Dental Intelligence, and today we have got some amazing content for you. Of course, coming from the one and only Katrina Sanders. And I know a lot of you guys have been watching these YouTube videos that we've been putting out there, and we appreciate you taking the time and really trying to perfect the craft that you're working on as a dental professional. And of course, the idea of all of these videos is really if we can just help you gain insight and perspective in some small way, and you can implement that into your life, the impact that you're going to have on hundreds, thousands of people in the workplace and in your personal life. And so I'm super excited to hear what Katrina is going to share today, specifically on case acceptance. So Katrina, the camera's yours.
Well, thank you so much, Jerem. And as always, thank you so much to the wonderful people of Dental Intel for the opportunity to share this information. Now, case acceptance is kind of an interesting topic because I think we're seeing a lot of information about case acceptance. What are the verbiage pieces? What are the things that we can use as professionals to help drive our patients to accepting the cases that we're presenting? And I wish that I could say that there was one quick, easy peasy recipe. I wish I could say you put part A and part B in a bowl, mix it up, and your patient is going to accept the case. But we all know that there are more layers to that. And so today I want to unpack a few pieces of those layers and more so just provide some insight, some food for thought into that recipe to really help understand why it is that you may be met with some challenge in your practice with case acceptance or the opportunities to optimize the work that you're doing to improve case acceptance. And in order to do that, I actually want to tell you about how I've drawn some inspiration in my case acceptance and the conversations that I have with patients really derived from one of my dogs, Baxter. So I have 4 rescue dogs. Yes, I have a problem, I know, but I have 4 rescue dogs and they are all amazing. And prior to the current global pandemic, I was on the road all the time traveling. And I would get home from a week-long, traveling stint. I'd walk in the door, I would drop my suitcases, and of course, guess who I'd be met with? My sweet boy Baxter. Isn't he just the sweetest thing ever? So this is my baby Baxter boy. And Baxter is so funny because he's the one dog that comes right up to me and starts wagging his tail. And I'll get down on my hands and knees. And anybody who has a dog, you know exactly what I'm talking about. Get down on the floor with Baxter and, oh, Baxter, you're so sweet. I love you so much, right? And Baxter, like any typical dog, gets so excited, starts to wag his tail. And the thing with Baxter that's so funny is that it doesn't matter what I say. He's excited to see me. I get down on that floor with him and I say hello to my sweet boy Baxter. The reason why I'm bringing Baxter up here is because when I get down on my hands and knees and I'm saying hello to Baxter, it doesn't matter what I say, but rather how it is that I'm communicating with him. For example, I could get down on my hands and knees and I could say, Baxter, you're so handsome, but I missed you and I'm going to give you a bunch of cookies. And he'd be so excited. But I could also say, Baxter, I love you so much and you're so stinky and I'm going to take you to the groomers. And he would also wag his tail because to him, it's not what I'm saying, but how I'm saying it. However, also with Baxter, I could say, Baxter, I love you so much and we're going to go on a walk. And anybody who has a dog, you know that dogs know that word. So one of the things that I recognized early on is that maybe our patients don't have the same intellect as Baxter, because Baxter's probably smarter than most of our patients. I'm kidding. But the reality is, I think that a lot of what we say is just white noise to our patients. I really do. I think about the times that I go and I take my car into the BMW dealership to get checked out, and the BMW dealership is telling me about my catalytic converter and all these things that I have no idea, albeit I did get a badge on car service when I was a Girl Scout. But I have no idea what they're talking about. However, with Baxter, I can say a certain word, and that word has a visceral, like Pavlov, reaction for him. He knows right away if I say walk that I'm going to be getting out that leash and he's going to go on a stroll around the neighborhood. He knows that he's going to go and visit all of his favorite trees and go bark at the dog on the corner. He knows that. His mind goes immediately to that term meaning something. So when we talk about case acceptance, when we talk about communicating with our patients and helping them understand, because that's where we need to start, is creating an understanding for our patients. If we can help our patients understand the why behind something by using appropriate terminology, I think we're going to have a better outcome for our patients. And that means that we need to be mindful of our patients' values and making sure that we are being reactive to what our patients truly express as far as their attitudes, values, perceptions, or beliefs. Our patients say things like, I'll only do what insurance covers, or maybe they believe that if it doesn't hurt, then nothing is wrong. Ultimately, our patients do have a fear of being sold something unnecessary. They have a fear that there is an elective quality to the work that we do in dentistry. And I think our patients are reticent. I think they sit down in those chairs and they have a concern that the case that we are delivering to them has an optional quality to it. Now, we all know from a core values standpoint that our patients absolutely have autonomy. They can 110% decide whether they accept that treatment or not. But what's not in question is, do they need that treatment? And that's where I think we miss the opportunity so many times with our patients. So one of the things that I really wanted to focus on in this program was understanding what those barriers are for our patients. Why do patients not accept treatment? What gets in the way? And in order to do this, I'm featuring a study done by Aura Pharma. So this study unpacked 300 patients who were surveyed. And all 300 of these patients have one unique aspect in common. All 300 of these patients received a treatment plan for 4 quads of scaling and root planing with local delivery of antibiotics. And all 300 of these patients declined their treatment plan. So Aura Pharma wanted to understand, why is it that these patients did not accept their treatment? And I want to put a little caveat out there. These were not patients that were all centralized in one area. They were not all patients of the same practice. These were patients that were peppered throughout the country that had this treatment plan delivered to them by different hygienists, different doctors corroborating on the diagnosis, different financial advisors or front office team members coming in and presenting that treatment. And so all 300 of these people, nevertheless, had the same outcome. So why? Now, Jeremy, you and I both know what the most common assumption is, right? I would, before COVID happened, I would travel and speak, deliver this program or deliver this study to hundreds of thousands of dental professionals. And I would ask them, what do you think it is? What do you think the number one reason is that patients decline treatment? And of course, Jeremy, what do you think everybody's number one response is?
Probably money.
Oh yeah,
Finance,
absolutely.
yeah.
Right. The insurance won't pay for it. It's the money, it's the this, it's the that, right? I mean, like clockwork, they say that. So interestingly enough, the number one reason why patients actually decline their treatment plan is they don't trust their dental health care professional. Now, that's a tough pill to swallow, because what it sounds like is this: I don't know, I'm going to have to ask my wife. Oh, I'm not quite sure. I'm really busy at the end of this year. Oh, my insurance isn't covering that. So I might do it at another time. But the reality is 87% of patients in this particular study said they did not trust their dental health care professional. The second most popular answer was they didn't understand the consequences of not undergoing treatment. So I know we're talking kind of a broad topic here with case acceptance, but this particular study looked at patients that had active periodontal disease and declined their treatment plan. So these patients didn't understand the consequences of not undergoing treatment. Right away, can we list off consequences of not undergoing periodontal therapy? Not just simply localized effects, like you could have advanced probing depths, bleeding upon stimulation, furcation involvements, bone loss, and ultimately tooth loss, where then we need to replace the tooth. And this is the path that we go down, right? You need to replace this tooth, X, Y, and Z. But what are the other consequences of not treating oral inflammation that has a systemic burden? What are some of the other consequences of allowing this chronic inflammatory condition to remain present in the gum tissues, right? The third most popular answer was they didn't even understand the recommended treatment. They didn't understand the way that we communicated to our patients. Interestingly enough, Jerem, cost ranked 5th in this survey. So patients' number one concern, although financials are going to be a concern, and I know we're going to do some other programs where we're going to talk about some of those, I want to remind the individuals on this call or on this program that the number one concern that I believe we need to focus on in dentistry is doing a better job of building trust for our patients. And that means taking a look at the things that we say. How is it that we oftentimes say things that can oftentimes derail our patient's trust? One of the ways that we do that is through our verbiage. For example, I get down on my hands and knees and I tell Baxter that he is so handsome and I love him so much and he's the best boy ever and I'm going to take him on a walk. And then my brother comes over and he says, let's take Baxter on a stroll. And then my friend Steven comes over and says, let's put Baxter's leash on and take him down the street. Well, all of those things mean the same thing. But to Baxter, walk is the term that he knows, that he understands. How often are we utilizing interchangeable terms that don't make sense to our patients? You need a non-surgical scaling and root planing, non-invasive, periodontal debridement, my favorite, deep cleaning. Let's do that. Let's call this procedure, it's basically like a regular cleaning, but deeper. How are we creating these confusing issues for our patients? The terminology that we're using isn't making sense. The patient is confused because the hygienist walks in and says, I'm concerned you have, periodontal disease and you need a deep cleaning. The doctor comes in and says, you're absolutely right. There's some gum inflammation here and we should do SRPs. And then, finally the office manager comes in and says, we're going to do scaling and root planing on the areas where you have active infection. And the patient's going, whoa, 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 whoa. I have infection? Another thing that I found very interesting was actually an experience I just had today. One of my high school friends, we've been friends for years and years and years. Her mom was actually my English teacher, and her mom had a tooth problem. So again, those of you on the call, you know what I'm talking about. Family members, a friend from home slides into your Facebook Messenger. Hey, I have a tooth question, right? So I had the tooth question and got the x-ray sent over, and tooth number 3 had a decent sized abscess. And the patient said, well, it was bothering me, but now it's not bothering me anymore. And my dentist said that eventually I'll probably need to have it removed. And we could go ahead and get that scheduled anytime before the end of the year. That tooth has infection on it. And so I told her, I said, this tooth is infected and that infection can easily drain into your sinus. I'm concerned. We need to have this tooth removed immediately. The fact that your body is shutting off nerve impulses to that tooth is telling you that your body is trying to reject that tooth right now. I'm concerned and we need to get that treated. I had no idea that I had infection, Katrina. Why is it that we're in a situation where we're not telling our patients about the things that we're seeing? I have an old adage, sugarcoating is decaying your practice. And I do believe that's true. I think a lot of times when we do sugarcoat things, when we use terminology like, I'm seeing a little bit of bleeding over here, or maybe we tell a patient, you've got a 5 millimeter pocket. Let's try brushing better in that area. Can you brush your way out of a 5 millimeter irreversible disease process? Absolutely not. And so what we're doing is we're creating this aura where our patients think that all they need to do is brush better. All they need to do is floss better. Instead of letting them know you have a disease process. And in order for us to treat this disease process, we need to perform active therapy, get you back into a stabilized state. And then only then will your at-home aids, your toothbrushes, your floss, whatever accoutrements you're using, only then will those pieces be effective. But when we tell our patients, when we start driving home some of these things, it's confusing. They think they can floss their way out of periodontal disease because we kind of told them they might be able to. What about some of the things that we're doing? And this goes back to clarifying the urgency of treatment. Keep in mind that what we're doing when we're diagnosing a case for a patient is we're providing them with a treatment opportunity and an outcome that we would like to see. Patients are coming in, sitting down in our chairs in a state of oral disease, and our role, our responsibility is to let them know about the disease in their mouth and the ways in which we can treat that. The question of, so how long can I wait on this? Isn't that the most annoying question you get asked? I don't know, because I'd love to tell you that this amalgam that's completely broken down and needs to be replaced will continue to remain in your mouth. But we all know Murphy's Law. You're going to bite down on something the Wednesday before Thanksgiving and your tooth is going to break. And now here I am trying to treat you and get you into some kind of a temporized situation right before the holidays. We have to create the urgency that our patients are going to understand. So it may look like this. Mr. Jones, I'm concerned about the gum disease in your mouth. That is an active infection where bacteria is leaching into your bloodstream. I'm so concerned about this that we need to start treating this right away. I do have some opportunities next week. I leave blocks open in my schedule specifically for patients who have this type of infection so that we can treat this immediately. Let's get you scheduled. Which of course leads us to the handoff. And this handoff is extremely important. The handoff creates an opportunity for everybody in the practice to be on the same page, which I find to be incredibly impactful. The handoff allows everybody in the office to be utilizing the same verbiage and the same terminology. It allows the hygienist to co-diagnose and educate the doctor on what their findings are. It allows the doctor to hear this information handed off by the hygienist and then agree, confirm those findings with the hygienist. And then when the hygienist then introduces the patient to a treatment coordinator or an office manager, that handoff continues. The patient is now hearing this treatment plan multiple times. And what they're really hearing is not the treatment plan, but the disease, the problem, the consequence, and the solution. So it sounds something like this. Dr. Donovan, today we have Mr. Jones. I noticed that Mr. Jones has stage 3 periodontal disease. This disease is active right now. He has generalized 5 to 6 millimeter gum pockets with active sites of deposit. My treatment prescription would be to perform active periodontal treatment. We need to perform this. I'm confident we can use a non-invasive approach, which I think is going to help Mr. Jones get him back into a stabilized state. Doctor confirms the findings, leaves the room, and now we're going to bring in Carly, my treatment coordinator. Carly, meet Mr. Jones. Mr. Jones has stage 3 active gum disease. Dr. Donovan and I are concerned about the active infection in Mr. Jones's mouth right now. And what we've treatment planned is a non-invasive, non-surgical periodontal treatment for him. It will take us about 90 minutes for each half of the mouth. This disease process is concerning to me. And I do notice that I have some opportunities next week to get Mr. Jones in. So let's find a time to coordinate and get him scheduled for that, please. Notice I don't mention the word insurance at all. And we're going to talk about insurance later on in this series, but notice I don't bring up insurance because that's Carly's job. My job as the clinician is to talk to the patient about the infection in their mouth. The handoff is not insurance driven, rather patient driven. I have a provocative idea. I think we need to stop providing patient education. We have to stop talking at our patients. Rather, we need to respect our patients. We need to provide relevancy. What does this matter to the patient? Why is this treatment plan important to this patient? And for every patient, that's going to look different. For the patient who's cost conscious, that may sound something like, the good news is we found it in its earlier stages. It will never be cheaper than it is right now to treat it. For the patient who's time conscious, who's concerned about spending out, crazy amounts of time in the chair, it's the good news is we found it now. While we can manage it now, if this breaks, we could be running into scheduling challenges. You may be traveling on the road. This could be a challenge for us. Remember, patients and adults are experiential, and they learn best through co-discovery. They learn best by us discovering alongside the patient, asking questions, learning about the patient's unique clinical parameters that elevate their risk for disease, and letting the patient know it is because of these elements that I'm seeing in your mouth. Your health history elevates your risk for various types of cancer, stroke, heart disease, upper respiratory tract infection. And so I am concerned because you have a family history of these things and you have gum disease. And we know that these two have an interdependent relationship. I'm concerned. Let's get this started today. Patients appreciate that approach because it's patient-centric. They don't believe that they're just receiving a bland, protocoled approach, but rather something that is very much guided and centric around their unique needs. Our opportunities begin by creating a perception of urgency. We know, and the research has told us, that if a dental professional is able to utilize or communicate the urgency, it drives a higher rate of treatment acceptance. Terminology like active infection is a term that does encourage immediate action, particularly by the patient. And we know that if we can educate our patient on potential consequences, particularly of periodontal disease, but let's take that, and again, this is a research study from Aura Pharma, let's take that and expand that out into anything. Let's talk about the hard tissue as well, that if we can help educate our patient about the consequences of not undergoing treatment, that we can help our patient better understand the reason why our concerns are so pervasive and help better drive our patients to case acceptance. It is my hope that this information provided a small over-the-balcony look at some of the small nuances within your practice that maybe could use some office calibration or some mild adjustments. And ultimately, it is my hope that Baxter's story will help you to better understand some of the terminology pieces that you can use to help drive your patients to excellence. From Baxter and I, thank you so much for joining me today. Please, if you have any questions, feel free to find me, Katrina, at katrinasanders.com. You can find me on my website, www.katrinasanders.com, or find me on social media. Thank
Awesome,
you.
Katrina. You are an absolute rock star. I love it. And look at this picture of Baxter. Wowzers.
Isn't he so handsome? I know. He's the best boy ever.
He is. Well, that was phenomenal content. We hear this often in leadership experts and communication experts, that the quality of our life is the quality of our communication.
Yeah.
And as if we can learn how to communicate better, it's not a matter of salesmanship. I love what you just said. It was a problem and it's a solution. Mm-hmm. And you're clearly communicating that problem. You're clearly communicating that solution and the urgency of that. And that's our responsibility, your responsibility as dental professionals, to make sure that it doesn't get worse.
Yeah.
You know, and so
Absolutely.
I love it. And that was fantastic. So
So good.
thank you so very much. And to our viewers, thank you for joining us. And once again, keep the Dental Intel YouTube channel in your favorites, as we've got a lot of content coming your way. And when you have 15, 20, 25 minutes, jump in there and watch one of those videos and be more aware of the things that you can work on to be that expert as a dental professional. So adios, guys. Have a good day. We'll see ya. Awesome.